and disclaimer, I don't claim myself to be an expert in this area. As Zara has pointed out, I had been exposed to the study of electron microscopy whilst I was in Liverpool Hospital, and that was quite a short exposure. And to me, this the whole experience is a learning process. So I will share the little experience that I have with all of you this morning. Okay, so let me share my screen. So I hope you can see my screen well, and I hope you can hear my voice loud and clear too. Okay. So just as an introduction to transmission electron microscopy. All right. So as you know, I mean, I hope you know that there are various types of electron microscopies. For today's discussion and for the usage, mainly the diagnostic usage of renal pathology, we generally use transmission electron microscope. So it has been established since the 1930s. And as we can see that light microscopy has been invented way back from the 1500s, late 1500. And just a comparison that immunohistochemical stain was developed about 10 years later from electron microscopy in the 1940s. Okay, so the transmission electron microscopy is a very complicated equipment. I do not wish and I do not have the technical expertise to talk in length about the equipment, but in basic principle, the microscope, instead of light in light microscopy, it uses electron beams. So the optimal resolution is way better than the light microscopy. So the electron beam would be transmitted through very thin specimen after we process, or what we call ultra thin sections. That is then being highly magnified, and we can get a very detailed image of the sample. So the specimen in the ultra thin sections are usually less than 100 nanometer in thickness. So that is very, very thin. So the transmission electron microscopy will allow us to see various characteristics of the sample, such as any internal composition, its morphology, which is our main usage in renal pathology and crystallization, etc. Yes, so just a very quick introduction to the machine itself. So it's a high voltage machine. So the electron gun will then beam the electron, and which will go through various levels of the equipment, and will then project image on the fluorescent screen in the camera. So it is like the image is black and white. So even though it is black and white, there are a lot of things that we can see in the image. Okay, so before we proceed, I will give you some examples of a few cases that have been that have come to me through referrals from various centers. But before we go through the various cases, I'll just briefly enlighten you on the normal structure of the glomerulus in transmission electron microscopy. So As we can see here, this is the mesangial cells, and the mesangial cells has cytoplasm, so we can see the cytoplasmic processes within the mesangial matrix. So these are the food processes from the podocytes, and these are the urinary space. So this is the external external surface of the glomerulus, into the urinary space. Okay, so this loop, which we will see in subsequent slides, is the capillary loop, and here we can start to see the fenestration of the endothelium. So, which then depicts the capillary loop. Okay, so if we analyze in the pathology, we will be looking for depositions, including electrons, electron-dense deposits, or any fibrillary structures or suborganizations. And the podocytes will be seeing whether there's any swelling of the podocytes, the food processes, whether it's effaced or not, and of course our very main, which we pay a lot of attention to, is the glomerular basement membrane. Okay, so this is another area which focuses on one of the capillary loop. Okay, so we can see a very nice food processes, which it's usually in singles, okay, and separated, giving rise to the diaphragm, okay, the slit diaphragms. Slit diaphragms with the glomerular basement membrane and the fenestrated endothelium, all are important in the ultrafiltration function of the glomerulus. Okay, so again, we can see the podocytes giving rise to the food processes, and these are the endothelial cells, the nucleus, which gives rise to the fenestrated endothelium, and this is one of the platelets that we can see within the capillary loop. Okay, so this is another higher power view. So focusing on the glomerular basement membrane, if you can appreciate, there are three layers, the more pale area, the more denser area, and another pale area. So it's like a sandwich. So the external most is the lamina rara externa. Okay, so the middle layer, which is the lamina densa, so it's more dense, and the internal most is the lamina rara interna. So the lamina rara interna then is attached with the fenestrated endothelium, whereas the lamina rara externa is where the food processes holds its part. Okay, so these are the slit diaphragms. Okay, so now let's go to some of the cases. I have about 7 cases in total, but we'll see how far we can go. All right, so I'll try to not talk too fast so that for those of you who are still not very familiar with renal pathology can try to follow through. Okay. So the first case is a 23-year-old gentleman. He presented with nephrotic syndrome, and he also has bilateral leg swelling for 2 weeks prior to his presentation. Otherwise, he denied any preceding fever or any URTI symptoms. His 24-hour urine protein was the nephrotic range, 7.28 grams per day, with a low C3 and low C4. The ANA is negative. The serum creatinine is slightly raised, 137, with 22 of albumin, slightly low, and but the ASOT is negative. So there was a renal biopsy done earlier, which showed a diffuse and global mesangiocapillary glomerulonephritis and this, with C3 and C1q positivity. Okay, so 3 weeks later, he represented, and this time he had more leg swelling, more acute injury, more acute kidney injury, the creatinine raised to 167. The albumin is otherwise 29. Okay, so again, the clinical impression based on the previous biopsy was mesangiocapillary, or now we call it or we used to call it the membrano proliferative GN type 1 with C3 membranopathy. Okay. All right, so this case was referred to me only sending tissue for electron microscopy. So, and the previous biopsy was done at another center. So I can't show you that. So what I can show you is what we got. This is the semi-thin section. The semi-thin section, by the way, is the section that we do after we process the tissue, after we resin block the sample. And so we made some cuts, some sections. It's like in paraffin blocks, but this is from the resin blocks. So we make sections just to ensure that we are we have got the area of interest that we wanted, which is, we need to have at least 1 glom for assessment. Okay, so we got a glom in this tissue, and the glom looks pretty lobulated. Lobulation of the glomerular tufts, as well as probably you're not able to see it very well here, but there are some, there's increased mesangial hypercellularity and the thickening of glomerular basement as well. Okay. In the background, we can see the some of the tubules having vacuolation. So in keeping with the kidney injury, right? Right. So now we shall move on to its ultra thin sections. Okay, so let's orientate ourselves first. So this is the urinary space. Okay, so and this is supposedly the food processes, which is all effaced, and this is the podocytes. Okay, and we can see that this is one of the loops. Okay. And this is the mesangium having increased mesangial cellularity. Okay. Okay, this is a better picture, hopefully. So if you can see that there are a few loops. Okay, so this is one probably more clearer loop to you. Okay, one capillary loop, this is another capillary loop, another one. So there's a few capillary loops. Okay, and these are the mesangium. All right, so the capillary loops appears thickened even in this lower power view. Okay, and if I can show you from the arrows, the yellow arrows. Okay, so this is one of the dense electron dense deposits. And this is seen, as I said, this is the urinary space. So this is the external surface. So this is a subendothelial deposition. Okay, so it's a big hump that we can see. On top of that, we can also see some, okay, so this is another loop. And we can see that there are some depositions as well. In the subendothelial area. Okay, so this is not very clear to you, I think, at this stage. Okay, so we can also see some more depositions here as well. Okay, I'll show you better pictures. All right. So again, to orientate ourselves, so this is the external surface. So these are the podocytes, which appears a bit swollen. Okay, so we can see some of the food processes here. So this is the one of the loop. So this is, if you can make out, this is the glomerular basement membrane. It's not a nice basement membrane, but there are also depositions, these electron dense depositions going inwardly towards the capillary lumen. Okay, so these are subendothelial depositions. This is an area near the mesangium, and we can see some granular electron dense depositions as well within the mesangium. Okay, this is just some artifacts. Okay. So more pictures, more higher power view. Okay, so we can see that this is supposedly the end of the normal lamina rara interna, but now we can see these electron dense deposits going inwardly. So these are the subendothelial deposit. Okay, so the one in the green stars, these are the effacement of the food processes. Okay, so this cell here is the mesangial cells. Okay, so let's look at more pictures. So I hope it started to get clearer and clearer to you. So again, orientation. So these are our external surface. These are your podocytes, and these are the food processes. Some of the food processes are effaced. Yes, some are okay. All right. So we can see more clearer of the subendothelial depositions as pointed out by the yellow arrows. Okay. So supposedly the glomerular basement membrane is just this layer, but now this layer is expanded and it is duplicated, and there is a new layer being produced, and this is the mesangial cells which we saw that it was proliferating, and this is the mesangial cell interpositioning, means that the cytoplasmic processes interposition in between the in the basement membrane, and there is a new basement membrane layer formed. Okay, so okay, let's look at other areas. So this is again the food processes which are effaced. Okay, we can see. Can you see like tooth-like going down inwardly towards the lumen? So all these are the electrons dense deposit of the within the subendothelium. Okay, and these depositions that we can see as well within the mesangium. So again, the electrons dense deposit, okay, more higher power view. So this is most likely the cells, mesangial cells involved in the interpositioning. Okay, so so these are again the subendothelial deposition. So I hope you can appreciate by now the nice downward depositions of the subendothelium within at the subendothelial region. Okay, and we also measure at various areas, and we can see that there is generally thickening of the glomerular basement membrane, which is in keeping with what we saw in the what was seen in the biopsy. Okay, so more of the electrons dense deposition. Okay. So this is, again, part of the cytoplasmic process of the mesangial interpositioning. Okay, so higher power view of the endothelial, subendothelial deposition and the food process effacement. Okay, so I think you've seen enough of the images. So in short, so there's increased ovulation that we saw in the semi-thins section, which comprises of the mesangial increase in cellularity. So there's also thickening of the glomerular basement membrane, there's duplication of glomerular basement membrane, and some interpositioning of mesangial cells. So there's extensive food process effacement, and there's granular subendothelial deposits, which we saw a lot, with some mesangial, I didn't show you in these sections the intramembranous deposits, but there are some intramembranous deposits, as well as, which I showed you earlier, the humpy subepithelial deposits characteristic of this condition, which is a type, what we used to call the type 3 membranoproliferative glomerulonephritis. Otherwise, there's no dense deposits of the dense deposit disease type that we can see in this case. So the final interpretation for this case is membranoproliferative glomerulonephritis type 3, whereby we have both the subendothelial component as well as the subepithelial component. So this is the type 3 called the variant. Okay. All right, so let's move on to case 2. So this case 2 is a 36-year-old gentleman. So he is a pre-transplant workup potential donor to his brother. And otherwise, he doesn't have any symptom, but during the workup, he was noted to have hematuria, and it has been persistent. No other renal symptoms, there's no hypertension or urinary tract infection, and there is a family history of glomerulonephritis. So during this, part of the workup, he was seen by the urologist, and relevant workups showed no abnormalities, including negative cystoscopy and the CTU. The creatinine was normal, EGFR was okay, no red blood cell counts in the urine. There is the blood, but otherwise no proteins or glucose, no history of lupus, no history of any gross hematuria, frothy urine, or swelling of the lower limbs. Okay, so the brother was diagnosed to have chronic GN, but they do not know what is the primary cause. Okay, so they want to rule out any underlying glomerulonephritis or any hereditary renal disease like Alport's or thin basement membrane disease for this patient as part of the pre-transplant workup, because he had microhematuria. Okay, so these are some of the sections that we have from the HPE examination. So we can see in this asymptomatic man with seemingly normal clinical picture, he has a focal sclerosing pattern. So in total, there were 17 gloms, in which 6 had been globally sclerosed, which is about 35%, and 1 has segmental sclerosis. There's also patchy mesangial hypercellularity, but no active proliferative features that we can see. Okay, so this is a normal looking glomerulus, and at the adjacent to it, there is focal tubular atrophy noted. Okay, this is the PAG stain, which shows 1 globally sclerosed glomerulus, and this is a relatively normal glomeruli noted, with focal tubular atrophy also seen. Okay, so basically, it was, as I said, a focal sclerosing pattern, and the immunofluorescence are all negative. Okay, so let's have a look at the electron microscopy images. I don't have, I couldn't find the ultrathin section for some reason. Okay, so I'll show you the ultrathin sections straight. Okay, so in this patient, let's orientate ourselves again. So these are our capillary loops. Okay, so these are the mesangial area. So these are the mesangial cells. We can see the 3 blue stars. So these are mesangial cells, and in other areas, just a little bit more. So this increased mesangial cellularity. There's more of the mesangial cells that we can see. All right, so we can see that this is the Bowman's capsule. Okay, and this is the interstitium outside of the Bowman's capsule. Okay, which is common. It is normal to have some collagen in the interstitium. Okay, so these are the parietal epithelial cells lining the Bowman's capsule. So this is the urinary space, and this is the podocyte. This is one of the capillary loop. So the podocyte is in this area looks quite intact, okay, and the capillary looks not too bad. Okay, so this is a closer power view, okay, of one of the capillary loop, and we can see that the thickness is okay. So usually we take the average of the thickness of the capillary loops of the basal membrane. So I think in this case, the average thickness was, can't remember. It is normal. The average thickness was normal. Okay. All right. So we can see some apoptotic body or debris. Okay. And this is the one of the so this is can you see the red blood cell here? So this is the one of the capillary loop. We can see the fenestrated endothelial cells. This is the endothelial cell. Okay, and this is the mesangial cells. Here in the mesangium, we don't see any electron dense deposits within the mesangial matrix, but we can see some, again, the same thing that we saw just now, apoptotic body within the mesangium. Yeah, otherwise, the food process is not too bad, pretty intact. Okay, here we can see that we can start to see some effacement of food processes. Okay, and this area shows again some effacement of food processes. Okay. This is the urinary space, and against some effacement of the food process. And okay, so this is one capillary loop with a fenestrated endothelium. We don't see any electron dense deposit. These are the extension of the cytoplasmic processes of the mesangial cells. Okay. And the thickness in average is normal, and it looks pretty in crude assessment. It looks it appears to have regular thickness. Okay, so yeah, the average thickness was 312, which is of normal thickness. So there's occasional apoptotic bodies. However, there's no collagen of fibril formation within the mesangium. But having the apoptotic body may suggest early FSGS, because the collagen and the fibrils are usually found in well-developed or advanced FSGS. So we saw some focal process of effacement and normal fenestrated endothelium and no electron dense deposits. So when we relate to the light microscopy examination, the immunofluorescence findings, based on all these, if we put together, it is appropriate to make the diagnosis of a moderately advanced FSGS, okay, with a significant glomerulosclerosis of 35%. Remember, this is a pre-transplant workup, otherwise asymptomatic with only microhematuria noted during the workup. So this is quite significant for this man. So most FSGS do present with nephrotic syndrome or at least a proteinuria, but some do present with hematuria. I think those of you who have been involved in renal biopsies found that quite a lot of cases of FSGS do present with hematuria. Okay, so for this patient, it is wise to advise caution for him to be a donor, as he has this moderate FSGS, and he needs to monitor of his progress himself. And if, you know, it can develop into a full-blown renal failure in the next 15 years if it's not being followed up. So when we relate this case to history of kidney diseases in the family and the brother needing a transplant, so this FSGS may be familial. Okay, so they wanted to rule out Alport, so there's no features to suggest Alports, because I will show you in later cases what are the criteria to call an Alports. And we can also exclude IgA nephropathy because nothing in the immunofluorescence, as well as no electron dense depositions that we can see. And it's not thin basement membrane disease because all the basement membranes are not thin enough to qualify for that. Okay, so it is a moderately advanced focal segmental glomerulosclerosis. Okay, so case 3. So this is a 28-year-old lady. She had 4 months. She's 4 months post-emergency cesarean section for preeclampsia. So she had underlying nephrotic syndrome with microscopic hematuria in pregnancy. The ultrasound Doppler showed the kidney were normal sized bilaterally with a bilateral parenchymal disease and bilateral simple cyst. Okay, and otherwise, it's possible still to be glomerulonephritis or peri-hereditary because there's strong family history of end-stage kidney disease, mother and sister since 28 young age, you know, having to be on hemodialysis, and they're not sure of the cause. So the C3 and C4 was normal, non-reactive to ANA, negative infectious screening. She has blood of 1+ with protein 3+. The UPCI, which is an estimate of the 24-hour urine protein, is estimates it's 6.2 grams per day. So it's in the nephrotic range proteinuria. And the creatinine seems to be declining in function. Okay. So in total, there were 8 glomeruli, not much for this case. Okay, but from the 8, we can see that 3 glomeruli showed global sclerosis elsewhere. Okay, so here in this PAS stain, we can see segmental sclerosis, and the adjacent we can see mild tubular atrophy. Okay, so we can see some segmental sclerosis, and we can see some extracapillary proliferation here. Okay, so here we see the segmental sclerosis, and again we see the extra glomerular proliferation, and it is surrounding the glomerulus. Okay. So this is the PAG stain. Again, we show some extracapillary proliferation, or seemingly looks like the podocyte. So podocyte hyperplasia, and it is going in between the glomerular tufts. So this is what we call pseudocrescents. So the immunofluorescence, otherwise IgG was negative, IgA negative. The IgM shows accentuation at the area of sclerosis, 2+, mesangial granular deposits. C3 accentuation at the region of sclerosis, but C1q is negative. And again, some accentuation at the area of sclerosis of kappa and lambda. Okay, so then we proceeded with the EM. So the semithin section, I think you can see one globally sclerosed glom there and one viable. Okay. So this is one of the viable glomerulus. And this viable glomerulus show mild increase in mesangial cellularity. But otherwise, in this semithin section, the tubules, the surrounding region shows quite back-to-back tubules. Okay, so the ultra-thin section shows fairly diffuse food process effacement. Okay, we can see this microvilli, which is when the food process is being injured. So usually we would see this non-specific reaction, which we call microvilli. Okay. So this is one loop, and this is another capillary loop, and this is another loop, and we can see some red blood cells within the capillary loop. Okay. Very crudely, we can see that the glomerular basement membrane is rather regular. Okay, again, we can see some areas having food process effacements. Okay. Here, more food process effacements within this is the mesangium, and we can see a few. This is one mesangial cells. Okay, and here we can see some apoptotic cells. So this is again the Bowman's capsule, and this is the parietal epithelial cells, and this is the interstitium, and this is one of the capillary loops, and this is the endothelial cells. You can see some fenestrated endothelial cells there. Okay, the food process in this area showed focal area of effacement, but otherwise not too bad. Okay, the thickness in general fairly regular and in the normal range. Okay, normal range. So as I said, there's moderate food process effacement, and the thickness is normal. Okay, so there's no irregularity in the glomerular basement membrane layer. No significant multi-lamination of the lamina densa or breadcrumb appearance, and there's some scalloping, perhaps I'm unsure of the significance, but all in all, it's not enough to call it an Alport syndrome. Okay, and this is also a suboptimal biopsy. So when we put everything together with the light microscopy finding, this is a feature of focal segmental glomerulosclerosis with the collapsing variant, which is in keeping with the acute kidney injury, and it is still an ongoing process. So given the absence of the clinical feature of sensory neuronal deafness or any eye abnormality, so Alport syndrome is unlikely. Okay, if we're not sure, we still think that it is possible, so we need to refer for genetic testing to see this collagen 4A3, A4, A5. Okay, so the sensitivity is 60%. So this is a collapsing variant FSGS. I didn't show you the area of ADIN with acute tubular necrosis and some moderate hypertensive vascular changes. Right. So just to show you very quickly what is Alport syndrome. So this is just to show you thin basement membrane disease, and this is what we would ideally see in the Alport syndrome. Okay, where we see the lamination or basket weaving appearance of the glomerular basement membrane. So this is the breadcrumbs that we see that breaks down the lamina densa in Alport syndrome, which we did not see. Okay, this is the alternating thick area and the thin area. See, this area is very thin, and the same loop, this area is thick. Okay, so the alternating thick and thin in our case, we did not see. Plus, there is no clinical feature to suggest Alport, so we excluded Alports at that stage. Okay, so I have 15 minutes to go. I have a few more cases. Can I still, I'll try to go a bit faster. So case 4, this case is a 20-year-old young lady. So she had nephrotic syndrome and 10 grams per day. Earlier biopsy was done and it shows MPGN with a full house IF. Okay, but otherwise, the ANA, anti-double stranded DNA, anti-Smith, ribosomal, all these, the ENAs are all negative. She also had hepatitis C and given DAA. Okay, so it is admitted to rule out the relapse of, is it MPGN or is it lupus nephritis? Okay, so the serum creatinine also has been slowly creeping up with normal C3, C4. Okay, so this is one of the glomerulus. Okay, there's a total of 17 glom and 7 globally sclerosed, which is 41%. And a few shows segmental sclerosis, and this glom shows increased in mesangial cellularity, in fact mesangial hypercellularity, with also thickening of the glomerular basement membrane. Okay, so we can see more of the rigid and thickened glomerular basement membrane and mesangial hypercellularity in this glom. Much of the same, looks more lobularized, okay, with mesangial hypercellularity and the thickening. Okay, so we can see more the thickening. So there's an area of sclerosis here. So it's an area of sclerosis, and if you can see this area, there is the tram track appearance along the capillary loop. Okay. Less obvious, but we can see some subendothelial deposition obliterating the capillary loop. Okay, and some more of the endothelial deposition. Okay, so this is the IF. The C3 shows C3, 3+ positivity along the capillary loop. IgM is 2+, and there's a little some positivity and 3+ positivity along the capillary loop of kappa light chain and lambda light chain, all granular in appearance. Okay, so this is the semithin. There's again the lobularization of the glomerular tuft with mesangial and endocapillary hypercellularity. Okay, so orientating ourselves again. So this is one capillary loop. This is the red blood cells within the loop. This is the mesangial cells. So increased mesangial cellularity. So there's 4 here. So this area we can see that there's some depositions within the basement membrane. Okay, if we look high power view, can you appreciate there is the deposition beneath the subendothelium, and again this is the similar interpositioning of the mesangial cells. Okay, so we can see the subendothelial depositions, electron dense deposits. Okay, so this is the normal glomerular basement membrane. What I mean when it is there's the interpositioning. So this is the part of the mesangial cytoplasmic process. So it goes in between. So it widens the lamina rara interna, and then a new basement membrane is formed. Okay, so this is the electron dense deposit within the subendothelial area. Okay, so this is the foot process effacement. Okay, so more on the subendothelial electron dense deposition, and these are the foot process effacements. So a better contrast highlighting the subendothelial electron dense deposit. Okay, more the subendothelial electron dense deposits with the mesangial interpositioning and foot process effacement. So this is the fused membranous proliferative and focal sclerosing pattern by light microscopy. And in view of the clinical, the morphology, the immunofluorescence and electron microscopy studies, this is in keeping with the membranous proliferative glomerulonephritis type 1, or now known as C3, one of the C3 glomerulopathy. C3 in this case is not lowered, but it is acceptable as about 1/3 and known to have normal C3 level. And the strong immunopositivity indicates an ongoing active disease. Okay. IF can be full house in C3 glomerulopathy, but this is not SLE because the criteria is not enough clinically and serologically to support SLE or lupus nephritis. Because of the chronic active changes, this case has a poor prognosis, and this lady needs active treatment. Okay. So in this case, EM is warranted to confirm the type 1 as well as to exclude the type 2 dense deposit disease, as well as to ascertain whether there's any type 3 component like we saw earlier. Okay. All right, so the next case is case 5. So she had persistent microhematuria, also planning to donate for her sister. The rest of the workup is negative. Okay, so this is normal looking renal tissue, cortical renal tissue, back-to-back tubules, many gloms. And true enough, the gloms looks as normal as you can get, just for you to appreciate what normal looks like. So this very normal looking glomerulus in PAS stain, in PAG stain, and in MT stain. Okay, so there's no abnormalities that we can see. The immunofluorescence were all negative. So this case, this is the capillary loop. Okay, so we can see these are the foot process. Okay, there are some microvilli formation. The basement membrane doesn't look very thin, and there's no irregularity of the, or rather there's no alternating thick or thin glomerular basement membrane that we can see here. Okay, so the thickness on average is of normal range. Okay, and it's pretty irregular in its thickness. Very nice fenestrated endothelium, and this is slightly swollen podocytes. Okay, otherwise normal looking. So this is the mesangial cells, and this is a remarkable mesangial matrix. No electrons deposits that we can see here. So there's no thin basement membrane disease. We don't see electron dense deposit in IF is negative, so not IgA, and not Alport syndrome as the features that I've mentioned to you earlier. Okay, so this is pretty unremarkable in light microscopy, negative for IF, no significant abnormalities that we can see in EM. So why does she have the microscopic hematuria? Well, if we have excluded all of the causes, so an idiopathic asymptomatic microhematuria is considered. Okay, basically we don't know why. But there's no significant pathology that we can see. All right, so the next case is a 51-year-old lady. She had, okay, so I'll go through very quickly, just focusing on some features only, okay, because we are running out of time. So 11 years post-transplant, and this time around, she has some deterioration of renal function. Okay, so she had been diagnosed on renal biopsy, previous renal biopsy, to have chronic transplant glomerulopathy before. Okay, yeah, so this is what they gave us. So we still see the rigid and thickened glomerular basement membrane with increase in mesangial cellularity. There's a total of 7 gloms. So we can see that there is the tram track appearance of the capillary loops, okay, in the PAG stain. We don't see significant tubulitis, okay, or PTC. There's some inflammation in the background with some regenerative atypia. Actually, this case we tried, there wasn't any tissue for IF, so we used up the tissue for immunoperoxidase stains, and we did not have enough for C4D or SV40. But from morphologically, there are, other than the regenerative atypia, we did not see any viral cytopathic changes. Okay, so so let's have a look at the EM. So we see that this is the capillary loop. These are a few capillary loops, and all the capillary loops looks to have expanded lamina rara interna, having this intervening lucent material within. It is thickened, about 410 nanometers in thickness. Okay, so all these are the thickened capillary loops with the lucent material within. Okay, So there is increased mesangial cellularity, as we can see here. There's 1, 2, 3, 4, 5. Okay. This is more of the loosened material within the lamina rara interna. Okay, and it is there's thickening of the basement membrane. Okay, this is one of the capillary loop, and we can still see the loosened material within. Okay, and just to show you more the loosened material, here we start to see some lamination. This is the capillary loop, but we also see this lamination elsewhere. This is the peritubular capillary. And the peritubular capillary, this is lined by endothelial cells. And we can see this classical peritubular capillary basement membrane multilamination, PTCB MML. Okay, and there's a grading in the BAMF scoring, mild, moderate to severe. Okay, so I think this is a moderate PTCB MML. Okay, so because we have the CTG and the the thickening of the basement membrane with this peritubular capillary basement membrane multilamination, so this is sufficient to call the features as chronic transplant glomerulopathy in the background of active tubular interstitial nephritis. Okay, I think this is a last case or second last case. Okay, so this is a 7-year-old girl. So she had nephrotic range proteinuria. Otherwise, she's completely asymptomatic, and the rest of the investigations were normal. No family history. So normal-looking glom. There are some segmental sclerosis that we can see. As you can see, this is the PAG. Okay. Normal in MT, and this is the immunoperoxidase stains because you don't have IF, no tissue for IF. So this is C1q, and it is very strong positivity within the mesangium of C1q. Okay, and also we can see a strong positivity in C3 within the mesangium as well, weak within the mesangium of IgM. Okay, so we can see this mild increase in mesangial cellularity. And here there's a quite diffuse food process effacement, otherwise quite regular basement membrane thickness, slightly swollen podocytes, okay. No electron dense deposits that we can see. No depositions within the capillary loops as well, with the basement membrane, sorry, okay. Yeah, so this patient had a nephrotic syndrome. She had FSGS by light microscopy. She had strong C1q staining. So this case is in keeping with C1q nephropathy. However, we expect to see some depositions, electron dense depositions within the mesangium of the capillary loops, but this is not present, but it can be present segmentally, and in this particular glom, we might not catch it. So the treatment and the prognosis is the same as standard FSGS, steroids. Long-term prognosis may not be as good. Okay, so is electron microscopy in renal pathology relevant? Still relevant? So I think I have illustrated in my cases that yes, electron microscopy is still relevant, is still important, and sometimes crucial. Some cases may not be electron microscopy will just support the diagnosis being made by the light microscopy and immunofluorescence and other immunohistochemical staining. But some diagnoses are crucial for pinpointing to a particular diagnosis. Okay, so there are many diseases that needs electron microscopy. It can refine diagnosis. We need to it can provide crucial information to collaborate all the information together to then arrive to a diagnosis, and allows us to directly visualize any abnormalities. So conditions like amyloid fibrils, which I did not show to you, or any fibrillar deposits, it's very important to be assisted by electron microscopy. Alport's syndrome is also a diagnosis needing electron microscopy, and thin basement membrane disease, dense deposit disease, especially type 2. Okay, and also minimal change disease, where we see diffuse food process effacement in an otherwise normal light microscopy. Fabry's disease, we can also see classical zebra bodies and tubular reticular structures in lupus and HIV infections. Some of other conditions is good to have, but maybe what we have is sufficient. But if we have, it will then support further the diagnosis that we had made. So, for example, immune complex diseases are common ones like IgA. So we may have seen IgA and made a commitment of IgA. Most of the times we do that, but sometimes the IgA may be very a faint deposition. We may just say there are some IgA deposits in like say focal sclerosing pattern. So IgA cannot be ruled out, and when we do electron microscopy, we may be able to see the better, we will have confidence in making the diagnosis of IgA by seeing the electrons dense deposits in the mesenchyme and paramesenchyme. Okay, so and the rest of these conditions is good to have, but we may, be able to make a sufficient and confident diagnosis based on our usual panel. Okay, so Zahra, I just have a little bit of slides just to enlighten on what the services that we have in UPM. Can I still go on?
Please proceed, Kak Fauzah. I was about to ask you about that, but now since you already brought it up, okay.
Okay. All right. So just maybe the next 5 minutes just to enlighten everyone the services that we have in UPM. So I started this service in 2018. I was trying out the system in 2017 with the help of many parties. Thank you very much, especially to Dr. Nik Hashima from HKL and from Selayang also offered me some cases to try out. So so I started that service and Alhamdulillah, praise be to God that we managed to run the service. So if any one of you want to request the EM service, just contact me, make an appointment, make sure I am around, and then if you got a date with me, then you contact Encik Rafi Uzzaman, who is at the IBS Institute Bioscience, where we do our electron microscopy tissue processing. So you have to get the fixative solution in a vial, the 4% buffered 4% glutaraldehyde. If you don't have, get it from IBS, or if you have in your laboratory, so you can get it there, and then arrange your transport to pick up. So the transport needs to be in ice. It needs to be maintained in the 4 degrees. Okay, for storage also it needs to be kept in the fridge at least 4 degrees Celsius. Okay, so the biopsy, the vial must be ready. So immediately put the biopsy into the vial containing the buffered glutaraldehyde, and then send through to the relevant area, the relevant counter. If from public MOH hospital, send to Hospital Sedang. I will, and if from private or university hospital, so it can go through HPUPM. So we will register in the system. Then I will bring the tissue and everything to IBS. Okay. So just some notes, please write in relevant details, adequate details for me to help me to collaborate all this information. As you can see, you know, we don't just based on the electron microscopy findings alone, we need to collaborate with all the other important piece of information. So preferably, you send in the whole set, the HPE, the IF, as well as the tissues for EM. But if you don't, if you just decide to send in the EM, please provide me the report that had been done, the HPE and the IF that had been done. And this is more for the nephrologist to send in good amount of tissue from the cortex, not from medulla, so that we can really identify the area of interest. Okay, so just some tips because of the cost of the electron microscopy. So for those from the government government servants, it is under GL, so they can claim later. Or they many centers now have identified you know, bodies, charity bodies to assist them financially. Okay, so this is Institute Bioscience, where we process all our EM sample. It is in the main campus of UPM. So this is my model, Dr. Irene, who's doing renal attachment with me now. Okay, so we keep it in the box with ice to maintain at 4 degrees Celsius. So the tissue, as usual, the identification, and then the tissue, we need to use this dissecting microscope. And this is a gel pad, and I will put a drop of the buffered glutaraldehyde and put the tissue on the tissue that I place on this gel pad. So looking down the microscope, I want to identify the area of interest, which is there glom or not. Okay, so this is what I'm trying to do, trying to identify whether there's any glom present. Okay, so because it's a very tiny tissue, so I need to look under the microscope for that. Okay, and so I make the appropriate sections. The sections need to be cut into 1 millimeter tissue sections. Okay, and this is an example of a tissue that I see directly under the dissecting microscope. I'm not sure whether you can see. You have to, you know, pull back your head from the monitor. If you can see this can you see these balls here? So these fine capillary balls, so these are your gloms. Okay, so usually if I identify that, so I will make some 1 millimeter sections identifying the regions of interest, because the tissue will be processed 1 millimeter in 1 millimeter sections each. Okay, so it's very, very tiny. This glom mainly shows this tissue shows mainly the medullary area. So you see the tubules, okay, but there are some glom as well that we can see, which is fine capillary balls. Okay. So just to show you some areas where they process the tissue. Okay. This is the resin, resin that they will then block the tissue. Okay, and they will polymerize the tissue. This is the block, the resin block. This is like a pencil. So this is the resin. This is the tissue that it is black because it is stained with osmium. Okay, so the end of this pencil-like resin block is where we put on the ultramicrotome and we will do the sections. Okay, so this is the grid, copper grid, where we place the section, very tiny sections on this copper grid. It's about 200 grids actually if you see under the microscope. And this is the ultra thin section where we will section, again under section using the microscope. And these are the semi-thins I was telling you earlier. So there's a few levels, making sure that we have the area of interest, in this case, glom. This is a higher power view of a glom of another case. So, and then when we've identified, then they will proceed with further sectioning, place it on the copper grid that I mentioned to you just now, and we place it here. And this is the TEM machine. So we then view the image on the screen here. And this is our scientific officer, Puan Ilmazian, who usually assists me with the interpretation and the image finding. Okay, so me, Elmina, Dr. Irene, okay, at IBS. And these are the staff that is in the unit microscopy IBS. Okay, so mainly Encik Rafiq Zaman and Puan Ilmazian, who's directly involved with the process. This is the head, Professor Dr. Zonita. So this is my last slide. Special acknowledgement to everyone from Histopathology Unit Hospital Sedang, from where I was trained in Liverpool Hospital, Sydney Southwest Pathology Service, all my mentors, Dr. Nick Hashima, Prof. Jim Yong. I remembered about this towards the end, so I didn't manage to get the pictures in for acknowledgement, but otherwise, I mean, I really appreciate them. And of course, my UPM faculty as well as HP UPM. Okay, so my motto or my advice is never stop learning, because to me, learning about electron microscopy is something new, and I'm still learning. And I will always be learning and getting to know the electron microscopy findings. Okay, and with that, thank you very much. Okay, back to you, Zahra.
Okay, thank you, Dr. Fauzah. Thank you for the very excellent talk. We have one question here at the moment. We'll start first with this question while waiting for other question to come in from the Zoom meeting or as well as from the Facebook. This is from Dr. Rosna. Is there any role of EM in making diagnosis of challenging cases of renal tumor?
Thank you, Dr. Rosna, for your question. To be honest, I have not been using EM other than in medical renal biopsy cases. Even when I was in Liverpool Hospital, the other usage of electron microscopy in their center was for endocrine tumors, CNS pathology, and ophthalmopathology. I have not seen its usage in renal tumors. Do you know if there is any utility in renal tumors, Dr. Rosna? I'm not sure whether Dr. Rosna can speak up.
I think Dr. Rosna needs to unmute.
Hi, Fauzah. Thank you for a very excellent talk. Enlighten us on Saturday morning. I also never come across. It just has been reading on a few literature and research with regard to assisting in making diagnosis for renal tumor. That's why I'm asking if you had come across if any research going on in the center that you have been there before.
I'm sure that in research, memang, I mean, electron microscopy, the bulk of the service is research. So yes, I'm sure if you can, think of a research to analyze further any renal tumors, memang that is the main usage utility for TEM. But for diagnostic purposes, I'm not sure how we can utilize TEM for diagnostic renal tumors. Yeah.
So maybe in future, there's a hope.
Inshallah, yes. We our electron IBS. I'm very proud to say. On behalf of my staff, I don't do it. They have been established a long time, and they have been very active, and they have been one of the active referral center for electron microscopy, and they do a lot of works in electron microscopy, TEM, SEM, both biological and material. So so if you want to collaborate and do some study using, looking at renal tumors using electron microscopy, you're most welcome, Dr. Rosna.
Yeah, maybe Zaira can pursue this since she's going to take up uropathology. Yes, Zara.
This is something should we thought over, I think.
Okay, thank you.
One question to Dr. Fauzah. Since you did mention about in regards to in helping in diagnosis of amyloidosis in renal biopsy, because since we knew, I mean, there is immunohistochemistry for helping in making the diagnostic part of amyloidosis. So how does EM can help in this aspect as well? Because I mean, yeah, as I mentioned before, we have the IHC of the amyloid protein, EE.
Conglomerate and all that, yeah. Yes, as I said, not all cases that is crucial to have electron microscopy, like in our practice at the moment in Malaysia. For renal biopsies, it's not a routine, it's not part of the routine panel to include electron microscopy, unlike where I was trained in Liverpool Hospital. Okay, so it is a routine for electron microscopy as part of the panel for assessment. So we will select cases. So I think the need for electron microscopy is when we are still unable to conclude amyloidosis based on light microscopy, based on the histochemical stains and including conglomerate and all that. Because as we know, even in the light microscopy, if we have a good tissue with good staining, we should be able to see the classical corkscrew, fringe on the rug type of morphology, and the conglomerate, salmon red positivity with the apple green birefringence under polarized light. So that's all classical, and we can easily make a diagnosis of amyloidosis. The cases which we are not sure, sometimes the conglomerate is not working, we want to confirm the diagnosis, then electron microscopy may be helpful. As I said, it does not necessarily conclude, but it will help to collaborate with other pieces of information. Because recently, Irene, myself got a case, and we discussed with Dr. Elmina as well, a case I got which was non-diabetic, but the morphology is really the nodular type of nodular sclerosis, like KW nodule-like, and it is a patient is non-diabetic at all, and we did congregate is negative, so we and they sent anyway the tissue for electron microscopy. So the usage of electron microscopy is to look for the characteristic of the depositions, if any, because like amyloidosis is differential, is as you know, the immunotactoid, the light chain diseases, the apa lagi, the diabetic, of course, glomerulosclerosis, and so all those have its characteristic apa nama itu, depositions within the mesangium. So we would then assess how thick it is, the arrangement, the organization, the polarity, and also other things lah. Then to based on those characteristics, whether it is likely to be amyloid or not in the case of amyloidosis, because in the case that I told you just now, the case we wanted to call it amyloid, but at the end of the day, it does not have the features. Actually, the depositions have overlapping features between amyloidosis to apa namanya, diabetic glomerulosclerosis, or at the end even an idiopathic nodular glomerulosclerosis. So we have to put all the information together, take into consideration the congregate staining, the clinical features, you know, the diabetic workup and all that, to then conclude what we would call at the end. So the question is asking about amyloidosis. To me, it will play a role in supporting the diagnosis that we already make, or confirm our impression, if confirm the impression that we already made, or support the overall will support the diagnosis of amyloidosis. But it is not, I mean, the electron microscopy itself, to call it electron microscopy, we cannot diagnose amyloidosis only on electron microscopy alone. We need to put together all the information. Is that clear?
Yes, thank you, Dr. Fauzah. I got one more question.
Yes, sure.
I mean, you have highlighted a few cases. I mean, what are the most common referral for EM that you get, or types of diseases that you get for EM?
The most common is pre-transplant workup. Pre-transplant workup. Usually they have already excluded everything else is okay, but they have hematuria, so it's the persistent microhematuria that they want to rule out. You know, is there any significant pathology that they need to be aware of in order to decide whether the patient is a suitable donor or not. So in the case of one of the cases, can't remember which number 4 or something. So she had persistent microhematuria. Then when we did we analyzed the light microscopy, IF, and electron microscopy, all negative or unremarkable, no significant pathology. So I mean, it's idiopathic microhematuria, so there's no reason not to proceed donating her kidney. vice versa, the second case that I presented also was a workup for pre-transplant, also persistent microhematuria, but that case noted the moderately advanced FSGS. And so that deemed unsuitable to donate his kidney. Yeah. So the most common is the pre-transplant workup, Zara. Yeah.
Another question in relation to the question. Actually, it's just a continuation of that question. Who are most of your referral comes from from private hospital or the KKMs, from which area, or Lembah Kelang, or most from the south or something like that lah.
Yeah, most of the referrals are from Lembah Kelang area, the Klang Valley, HKL, Hospital Selayang, because those are the active transplant centers. But I also receive from in-house, like Hospital Sedang, and I have also starting to get referrals from private centers. Yeah, so it's but mainly still Klang Valley. Actually, a few people already asked me, even from the start of my when I wanted to start this service, whether I can take cases from out of Klang Valley. Actually, if you can, there's two things. One, if you can ensure that the transportation can maintain the 4 degrees storage, 4 degrees Celsius storage throughout, then you can. And then secondly, preferably for optimal fixation, because as you know, electron microscopy, it is very, very crucial, unlike microscopy, unlike IF. It is crucial to optimally fix the tissue, because in the ultrastructural level, ultrastructurally, it will be very obvious if there has already been degenerative processes. So if the tissue has degenerated, so we are unable to assess the most important place that we want to assess is at the glomerular basement membrane. As you can, hopefully you can appreciate from the start of my talk, the glomerular basement membrane is an area which is relatively thin, and we need to go at a very high power to then assess what is going on at the glomerular basement membrane. And this area is very sensitive. So if you don't fix it properly, then you might, after all the sending, the arrangement, logistic arrangement, when it arrives to us, then we are not able to give you the best interpretation. Okay, so because of that, ideally, at centers like, say for example, in Penang, if you want to send to us, you can, after the nephrologist had put in into the 4% glutaraldehyde, buffered glutaraldehyde, so it will go to your lab first, and you identify the tissue and section it into 1 millimeter sections, identifying the regions of interest, like what I show you just now. And I looked under the dissecting microscope and sectioned the tissue, identifying the area of glom. So ideally, usually I would separate vial A is those with that I'm sure that has gloms. And in vial B are the tissues that either I'm not sure whether there's glom or I'm sure there's no glom. Like I know this is cortical region or it's only fat, so I will separate it. So when I have sectioned it into 1 millimeter sections, this ensures that there is optimal absorption of the fixative into the tissue, and so the tissue will be preserved optimally for the optimal quality of the image. So if you can do that at your center, sectioning, identify and section at 1 millimeter sections, and put it in a new 4% buffered glutaraldehyde and send it in a storage of 4 degrees Celsius, then yes, by all means you can send. Okay, that's one option. And then the second option, which I am still working on that, because we do that in, it is a practice, and it is an established protocol where I was trained in Liverpool Hospital. There's 2 other alternatives. We can use paraffinized block. So from the paraffin block, we identify the area that has gloms. We deparaffinize the tissue, and then they will process the tissue as the protocol. So the deparaffinization method too, we have not optimized. That led us to the inability to to see a good image. So as you have understood from my presentation just now, the TEM is a transmission electron microscopy. The electrons must be able to transmit through the tissue. So because if the tissue is not completely deparaffinized, so the tissue will be blocked by this paraffin, and so we cannot see the image. So we are still working on that. Hopefully I will have a master student soon, which we will embark in getting that protocol right lah. So you can ideally look back at cases because sometimes you only can do one time of biopsy, so you can get the tissue from previous paraffin block, and analyze that tissue for TEM. Or secondly, we can also, if memang really desperate, we can use the tissue that we have already placed on the glass slide. So we can take the tissue and process the tissue for TEM as well. Yeah, so there's a few alternatives.
Since the transportation is quite challenging, Dr. Fauzah, do you know, I mean, I know this is on the side of clinician, but you know if any of the nephrologists do help their colleagues, especially from, out of this Klang Valley to, it's like send patient to have their procedure rather than doing in their own hospital, but doing in either Serdang or UPM, because for us in Selayang, especially for the HPB, hepatobiliary, sometimes we do have patient just coming in to do some EUS for the pancreas and the hepatobiliary tract, and then they then they will send back to their own hospital. So just to get the diagnostic material, because it's a bit difficult there. Is there?
Yeah. We do have situations like that. Of course, now during the pandemic, it's more difficult. But previously, there were a few cases, like 1 or 2 cases, where they send the patient, as you said, to be to have their renal biopsies done at the center, Serdang or wherever nearby centers, so that it's easier in terms of the transportation. Yeah, that's another way of doing it. Send the patient, not the tissue.
Okay, we have one more question from Dr. Moha here. Since you did mention about patient getting funds to fund their EM procedure. So the golden question: how much does it cost? Any charges for that?
Yes, we do have a charge. The charge is mainly to for the maintenance of the TEM machine. It is, as you can see just now, it's a very big machine, very complex, and the more higher resolution that you can get. So the finer, all the parts are, so those are for the maintenance of the TM. Okay, so it costs for my center is 950 ringgit. Yeah, so that's the charge lah. So all inclusive of all the reporting. Yeah.
Okay. Thank you once again, Dr. Fauzah, for everything.
Dr. Maha wants to ask, is it?
Yeah.
Yes, yeah, Maha wants to ask. Go on.
Boleh dengar?
Boleh.
Boleh dengar?
Ya, boleh dengar.
Oh, sebab saya case lah last 2 months. Clinician tanya pasal EM ni, so that's why I asked. I'm tak sure lah kami nak hantar daripada Sabah ni macam mana, because we have that case, and then previously we used to send fresh tissue to KL lah, HKL before this, but I'm not sure EM or not. I don't think it's EM, it's IF before this, because we practicing sending all renal cases to KL lah before we have our own facility of IF and everything. So I about EM. So if clinician ask macam mana nak hantar, ada tak possibility kami boleh hantar spesimen daripada?
Boleh hantar spesimen saja, tak ada masalah. Cuma maksudnya tak ada masalah untuk kami terima, tapi as you said, the challenge is the transportation tu lah, bagaimana kan. Kalau you boleh get a good I think a storage yang boleh keep the tissue to at 4 degrees, I mean maybe investing on a good storage lah, yang sebab kalau ada my scientific officer Encik Rafi tu, dia kata dia pernah bawa tisu untuk EM daripada Kelantan balik ke sini, which takes about 6, 7, 8 hours kan macam tu, letak dalam apa tu ice box tu, dekat dalam yang a good one lah, yang macam camping punya ke apa ke, yang kedap udara yang boleh maintain the temperature tu. So dia kata tak ada masalah, dia boleh travel on the road punya travelling, bawa tisu tu okay je, good preservation. So ideally kalau dengan apa naik balon ni, naik flight ni should be like faster lah kan kalau compared to on the road tu. Cuma macam mana logistik tu bagaimana tu lah. Sebenarnya boleh.
Saya rasa boleh samalah dengan sebab masa biopsi sekarang pun kami masih hantar ke HKL. So basically clinician dia akan liaise direct to yang dengan dengan technician di HKL. Maksudnya ada yang tunggu di airport and then pergi ambil terus. Saya rasa if is something that like clinician yang perlukan EM, I think maybe in future saya boleh relax, maksudnya boleh minta kerjasama daripada pihak UPM lah kot. Maksudnya possible, maybe we can discuss we as maksudnya as orang tengah, but basically like masa biopsi dia tak melalui, not through us anymore. Mean clinician they send straight away to HKL. Mean dia ada cara dia, which saya rasa Dr. Zura and Dr. tahulah cara dia, because we don't maksudnya they don't inform us anymore about masa biopsi. I think I think the same way goes to EM lah kot, renal. So possible in future kalau saya akan cuba discuss lah dengan Dr. Fauzah if they really need EM, because last 2 months lah dia ada tanya, possible tak di Malaysia we send EM. I can't remember what case is that, because it's not my case, it's one of my colleague-nya case lah. So maybe in future saya minta direct contact Dr. Fauzah lah kot.
Boleh. Itulah saya just to on that note, saya rasa rather than dia orang hantar sendiri, which memanglah sebab dia biasanya mungkin dia bayar sendiri, patient bayar sendiri ke, dia tak melalui billing hospital semua kan, that's why dia direct, dia bypass je hospital tu, dia terus ke whichever center tu. Tapi saya rasa penting sebelum di transport tu kena dissectionkan dulu for optimal fixation. Itu penting. So bagi saya kalau boleh dia mesti melalui lab tu untuk dibantu untuk dissectionkan dulu. Bila dah dissectionkan tu, tukar dia punya buffer punya glutaraldehyde tu, and then baru transport ke sini. InsyaAllah kalau perlukan bantuan, dan kita boleh buat macam online punya teaching lah, macam apa cara macam mana nak section, nak identify tu, tak susah mana pun. I'm sure you can do it. You just need a dissecting microscope, that's all. Yeah.
Kami tak ada dissecting microscope.
Simple je microscope tu sebenarnya. Mikroskop tu simple je, dissecting microscope tu. Dia sebenarnya untuk, kalau mikroskop tu dia nak tengok bug and all that. So kita just nak tengok very crude punya assessment of the tissue lah sebenarnya. Kalau kita guna kanta pun sebenarnya boleh. Kanta tangan tu, kalau dia identification pun boleh juga. Apa-apa yang boleh nampak the glom tu lah basically.
Okay.
Kita boleh bincang lagi.
I think kat Selayang kita orang guna kanta, tapi kita orang, I think the clinician already dissect dan bagi kot. They did not go through us in the lab because kita nak cepat kan. So directly to Kak Fauzah, I think, right? But then once the result comes in, only kita orang akan masukkan because we want to keep it within the system. So nanti kita orang akan masukkan your result. Sometimes I think Kak Fauzah directly send emails to me as well, or one of my SOs. Then we load up into the system. But in terms of masa transfer tu, I think the clinician directly lies with your team. I think Dr. Fauzah?
Yeah, betul.
But for IF, yes, we don't have dissecting microscope, but we do use the kanta lah to make sure we have glom, then only we proceed.
So I think it's doable, but we just need to try to think outside the box, macam mana logistic wise lah. I think possible je.
Okay, thank you. Nanti kalau ada case kami akan discuss dulu lah. Let's say
Boleh.
Okay, we have one question from Dr. Elmina. Dr. Fauzah, how long the tissue for EM can be in glutaraldehyde without compromising the architecture?
Okay, there's a few school of thought. Baru-baru ni kami ada a webinar lah with Renal Society from India. So yang tu ada one of the pendapat is dia kata 6 hours hari tu aku tak silap. Tapi to me, into my practice, it's like 16 to 24 hours lah is okay to be in glutaraldehyde, but we need to section it dahulu. So that's why upon arrival dekat lab, terus kita sectionkan dia supaya dia optimally being infused by the glutaraldehyde tu. Then after 16 to 24 hours, then we within 16 to 24 hours tu, we then change to sodium carcadylate buffer. Sodium carcadylate buffer tu is the one that is yang kata kalau kata infinity macam tu lah, maknanya you can keep it in sodium carcadylate buffer for as long as you want. The tissue tu is fixed lah, forever fixed. So dia sebelum nak sampai ke sodium carcadylate tu lah yang challenging tu bila dekat glutaraldehyde. But having said that, macam I'm not sure because I don't have much experience in terms of experimenting how long the different timings or the different duration within glutaraldehyde before it degrades tu. I'm not sure, but that's our practice lah. 16 to 24 hours maximum in glutaraldehyde, then we change it to sodium carcadylate buffer.
All right. Thank you, Dr. Fauzah. I think yes, we have a very fruitful talk and discussion. I think we'll have to end it here. Sorry lah, Dr. Fauzah. It's a bit more than 11 o'clock now. It's 11:46. Anyway, before we end this session, just to like to remind everybody. IAPMD will be holding the annual scientific meeting virtually 5th to 7th October this year. So, and the abstract submission is until 31st July. So whoever wants to send their abstracts, feel free to send your abstract, and be sure to register before you send your abstract. Okay, I think that's all. Anybody from Kuantan would like to add on? Dr. Arfa, Dr. Suhaila?
Tak ada dah. It's actually the same like what you mentioned just now. It's still open for registration until 31st July, and all are welcome. Thank you.
Okay, thank you, Dr. Arfa. With that, I thank you everybody for participating in this session this morning. Stay tuned, we'll be having our next session in August with Dr. Wan Faizia on thyroid. Okay, right. Okay, thank you. Bye.
Thank you, everyone.
Thank
Have
you,
a good
Dr. Fauzah,
weekend.
once again.
Thank you. Thank you. Assalamualaikum.